Welcome everyone to today's program. My name is Shannon. I'm with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time that we have, and we'll follow up on questions we do not have the opportunity to address. You will receive an email within a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce one of today's presenters. Sean Slavinsky was named the Chief Executive Officer of Care Innovations in October of 2013. A passionate thought leader in the healthcare and wellness industries, Sean is a proven innovator and entrepreneur with an established track record in defining and building businesses from concept to viability. Sean has demonstrated great success in building pioneer products that define and lead their market segment, while being highly adept at building distribution channels on a national and international scale. Sean has held significant senior leadership roles within the industry, most recently at Humana, serving as Segment Vice President of Humana's Health and Productivity Solutions Business Group. In this role, he led hundreds of employees in 4 industry-leading wellness businesses, aligning them into a common vision while bolstering expertise in population health and well-being. It is now my pleasure to turn the floor over to Sean to begin today's presentation.
Well, thank you very much. He sounds like a wonderful guy. I wish I knew him. Welcome, everybody, to this webinar. We're very excited to be presenting this to you today. You know, I did an experiment over the last week in all the meetings that I was in just to kind of test accountable care and how important and top of mind this is to people within the industry. And in 90% of all my meetings, without prompting, accountable care came up as part of the conversation at some point in the first 10 to 15 minutes. So we know this is on the top of everyone's mind as we shift from fee-for-service to more of an accountable care type system. Today's webinar, I think, is going to bring some wonderful education from our fantastic panelists. And also, we want to spend most of our time on question and answers so you can get the greatest value out of this time together today. With that, the nature of the webinar, everyone's going to do just a brief introduction of themselves, talk a little bit about who they are and where they came from, and give some perspective on the situation within the industry that then leads to how they're looking at accountable care within the space. And then we'll open it up to your questions. And then on that topic of introductions, and since we're sponsoring this, we get to put a plug in for ourselves, but I know that's not why you came, so I'll keep it very brief. So we could advance to the next slide, please. And the next one. I will leave you with this before we jump into the time that you really want to spend. With Care Innovations, as you all think about your strategies around accountable care and how technology plays a role in reaching into the home or wherever your patients may be to make that more effective from an outcome and cost perspective, we'd appreciate it if you'd think of Care Innovations. We help our clients from the very beginning of just thinking about how to incorporate technologies to engage people in their homes, all the way through analytics and logistics to deliver those services so that you can get the outcomes that you need. So as you're thinking of technology in the home, in accountable care, please give us a call. We'd be happy to work with you and share with you what we've learned. On to the next topic then, if we could go to the next slide. Chris, I'm going to turn it over to you and allow you to introduce yourself and take it from here.
Great. Thanks, Sean. Thanks for having me today, and thanks everyone for joining us. This is Chris Daw. I'm Managing Director at Evolent Health. Evolent is a healthcare company based in Northern Virginia, which partners with healthcare systems to design, build, and operate in a long-term partnership format their value-based businesses. We're working with partners from all around the country. I'll just spend a few minutes at the end of my presentation talking a little bit about how we are active in the healthcare transformation space, the topic of our chat today. Just a quick word about my background. I started my career in the delivery system at Partners Healthcare up in Boston, but spent much of the last decade here in Washington working in federal policymaking Spent about 5 years in the Senate, most of that with the Senate Finance Committee, working on the development and passage of the Affordable Care Act. And from there, I transitioned to the executive branch and spent the last 3 years at both HHS and the National Economic Council at the White House, implementing the elements of the law that focus on health system improvement and driving affordability and quality improvement. So what I wanted to focus on today, if we could click to the next slide, are a few of the high level, at the national level, the high level public and private sector forces that are really driving a unique transformational moment in our healthcare system, and talk a little bit about some of the recent developments, again, from both the public and private sector that are trying to be even more explicit about their desired pace and depth of change in the healthcare system, in particular with regard to payment reform and the migration from volume-based payment to value-based payment. And then, as I mentioned, I'll just spend 2 minutes at the end telling you a little bit about how we are playing in that space here at Evolent. So on the first slide, there are many factors that are driving transformation in healthcare and making it, for my money, the most dynamic industry in the country and in the world right now. And some of those factors include technology and regulation and changing consumer buying patterns and disruptive innovation in general. Those are forces that have transformed and changed other industries, financial services, media, the airline, travel industry, and they are also playing a big role in this unique change in our healthcare system today. The focus of my remarks today, however, are going to be focused more around payment reform, so ways in which public and private payers are changing their reimbursement strategies to focus less on the on payment for the volume of care delivered and more for outcomes and affordability. And part of that involves a migration toward risk-bearing payment mechanisms for providers. And so this is something that has, as you can see in the slide here, going back a decade, had very little traction and is certainly contrary to the traditional fee-for-service approach. But as we're seeing and as we're tracking this here at Evolent, that has grown significantly today and will grow, we expect, by 3x between now and 2018. And with that, our estimates are that providers and health systems will actually be at risk for half of the nation's population by then. So really stark change in the approach here and on a very quick path. So let's jump to the next slide and dig in a little bit more on Medicare's approach to payment reform. So in late January, Secretary Burwell at the Department of Health and Human Services made a truly historic announcement and commitment on behalf of Medicare. First time ever that Medicare was explicit in its commitment to migrating in Medicare fee-for-service, its payment mechanisms away from volume and towards value. Specifically, they announced that by 2018, more than half of their payments to providers through Medicare fee-for-service will be in the form of alternative payment models. Just to give you a sense of, I'll talk in a minute about what those are, but to give you a sense of perspective here, in 2008, that number was effectively 0, and today that number is in the range of about 15%. And so when we, alternative payment models as defined by CMS and HHS are not your traditional pay-for-performance and other value-based purchasing programs, if you will. These are real payment reforms that include accountability and ultimately financial responsibility on the part of providers for populations of payment of patients over a year or over an episode that spans multiple sites of care, where providers are being held accountable for the total cost, quality, and care experience of the care they provide. And those words are really important. Total cost, total quality, and total experience are really moving away from a siloed individual approach to one that really focuses on the whole person. So that is the major market signal and unique in its explicit nature of both the depth and the timing around it. So that certainly has galvanized, I think, quite a bit of interest and movement in the market, just with having the world's largest payer come out and be that specific with where it's going. Let's click to the next slide to get a little sense of what's been happening on a similar path on the private sector side. So there was a group of healthcare stakeholders that was launched at the end of January as well, called the Healthcare Transformation Task Force, a group that I helped pull together and continue to serve on the board of, that is essentially a group of providers, payers, purchasers, patients, and other partners for those stakeholders that wanted to do three things to accelerate the migration to value-based care. The first was they wanted to send a private sector-based market signal. So in the same way that CMS and HHS were feeling that the pace of change and acceleration was being held back by uncertainty about how quickly the world was moving towards value, these private sector actors wanted to do the same. And there were about 25 or 30 in the group. This is just a random collection of them, and you can go to the website hcttf.org to see the full group. But a critical mass here of folks from each of these 4 Ps, or 5 Ps, if you will. So the first was send a market signal. Second was start to align approaches to value-based care. So to the extent that various payers or providers are either sponsoring or participating in an ACO program, are there ways to find more commonality than less, to have the focus be on providers expanding the book of business and value as opposed to trying to figure out methodologies and the competing approaches. So aligning methodologies and approaches was goal number 2. And the third was, out of this work, to develop policy input that's timely, relevant, and actionable to make sure that the public payers, both the federal and state level, can keep up with the pace of change. On the next slide, just a little bit more on the guiding principles. So you can see here on the top in bold was really the market signal. So when the group launched in late January, each of the organizations made a commitment to shift 75% of their respective businesses to be under value-based care contracts by 2020. So you can see here it picks up on the goals from HHS, from the public sector, and actually takes them and exceeds them going out a couple more years. And importantly, using an almost identical definition of what value-based care is. So you can start to see a public and private consensus around what real value-based care is. And again, it's oriented around total cost, total quality, and total experience for populations or for episodes. But then from here, I won't go through all of these, but essentially the group is trying to help contribute to the design of programs that provide for reasonable returns, and importantly, looking to see total growth in healthcare costs not exceed the rate of growth in GDP. So it's not just about participating in these programs, but actually succeeding, while also creating multi-payer participation and developing and equipping stakeholders with the tools necessary so they can actually succeed. Quickly on to the next slide, just a little more flavor here from this group in terms of the work groups. So the heart of this effort is to develop work groups that will seek clarity and consensus and alignment on discrete issues and run-to-ground consensus approaches in very short order. So this has started with improvements to the ACO model, including a public-private set of recommendations that are on the task force website and were the basis of their comments on the CMS Medicare Shared Savings Program proposed rulemaking. Looking at developing some tools to allow providers to have a better understanding of bundle payment approaches and methodologies available to them, and then digging in a little bit on high-cost patients, where there may be either a need for best practice sharing or perhaps new care delivery or payment models to support investment and returns both for provider and patient for the sickest, highest cost patients. So I'm going to wrap up here real quickly and get on to the other panelists. But so in this changing market on the next slide, give you a sense of what Evelyn is up to and operating, again, in long-term financially aligned relationships with systems around the country. You can see in the sort of dark blue, almost black states are where we have long-term agreements in place today, and are working in various stages with partners from all around the country. Starting to see some results here that are proving concept that it's possible to take pockets of excellence and in using and leveraging a national infrastructure that Evelyn is able to build to drive results pretty quickly. Then I'm going to just jump to the last slide and wrap up to give you a sense of how we're doing that. We have a suite of solutions that we develop and implement in conjunction with our partners that can range from the kind of high-level strategic and operational blueprint or strategy that can include helping bring to market population health and value-based care strategies, whether that be with your own employed population for a health system, through risk deals with other private payers, or developing and branding and bringing to market your own health plan. And then within the population health component, the value-based services organization, including developing best-in-class population health and clinical care programs, aligning the delivery network, and also having a kind of a unique technology platform that makes all this run and is able to drive impactable, actionable results. So we do, in some partners we work with, we bring to bear the full solution, and in others we may be executing against one or more of the individual capabilities that we can bring to bear for the partners. So I'll wrap up there. Looking forward to the question and answer and the presentation from my other panelists. Thank you.
Mitch, we'll turn it over to you.
Great. Thank you, folks, to the audience and the organizing teams at Becker's and Care Innovations. It's a great honor to be here with you today. Hope we can generate some great discussion from this session. My background, my college degree, biotechnology, graduate studies, health economics, 5 years in the pharmaceutical industry, 10 years at GE. And as a quick primer, GE Healthcare manufactures imaging technology, molecular diagnostics, healthcare IT, and biomanufacturing equipment. And so my team's role at GE, we conduct research to understand the value of healthcare technology, and we make forecasts about the global healthcare economy. So next slide, please. So here you see the two faces of accountable care. If you take a snapshot right now, today, we see the ACO model has grown. So right now it's trending at about 18 million covered Medicare lives. That's about 6% of the U.S. population, right in line with the slide that Chris shared, and potentially heading to a very large portion of the population covered. But at the same time, you see hospital margins declining and, in fact, being squeezed to historic lows. So next slide, please. When we talk with executives and administrators, providers of healthcare, this theme keeps arising, this common theme, similar to what Sean was kicking off at the start, which is, how do I keep patients out of the hospital and keep the lights on inside? Keep patients out, that's accountable care, population health. That's the left-hand side of that graph I showed you, which is ACO growth growing. But the right-hand side, how do I keep the lights on inside? We are still halfway, 1 foot in the world of fee-for-service, right? Half of a hospital's revenues are coming from fee-for-service. And so we call this the new paradox. We think this is going to be prominent on decision-makers' minds, on providers' minds, as they prepare for the future and look towards Healthcare 2020. Now, in the old world, the hospital was the dominant structure on the hospital landscape, but see how the landscape has changed, right? All around the hospital now are new business models, new revenue streams, potentially eroding the hospital's revenue streams, potentially complementing the hospital and their strategy for growth, okay? But you can see the landscape has changed. Next slide, please. One of the big factors that we see driving a new race towards productivity as hospitals try to reconcile this new paradox is high-deductible health plans. So over the past 10 years, high-deductible health plans have grown from about 1 million of the population to about 17.4 million now. So again, this is about 6% of the U.S. population. High deductible in a fee-for-service plan that's defined as greater than $1,150 per individual or $2,300 per family. The key change with this change, with consumers being more on the hook financially for health care, is what always happens when consumers are on the hook. Okay, number one, they want value, and number two, to get value, they need transparency. And so you can see the high-deductible health plan model is beginning to disrupt healthcare. People are more open to seeking care in retail settings or more convenient settings. And indeed, people are changing in their attitudes and in their healthcare seeking behavior to look at alternate sites of care, and they're becoming more quality savvy, more value savvy as they do this. Next slide, please. This is a second trend that is underlying this race towards productivity, and this is labor costs. Okay, so this study was published by the U.S. Bureau of Labor and Statistics. There was a second study in the New England Journal of Medicine published in 2011 by Kocher, and these two studies have really had stunning results on the way we think about healthcare productivity. When you look at 20 years ago, okay, any healthcare worker, the number of tests they could perform in a given hour, the number of tasks, the number of procedures they could perform in a given hour, that number has not improved. Okay, the healthcare labor force has not become more productive over the last 20 years. And so how have we responded to increasing demand for healthcare? Well, that's the top gray line. We add more workers. We meet the demand by adding more hours to our labor. We don't make our labor more productive. Okay, so now this model is potentially no longer sustainable. So recall my first slide where margins are being squeezed to historic lows, and also that half the cost of delivering healthcare is labor. Okay, those two facts make it hard to see how we can continue with adding labor hours as a sustainable way to meet future healthcare demand. Okay, now bear in mind our relationship with healthcare labor is complicated. Healthcare is about 8% of GDP. Forecasts are that healthcare will add about 5.6 million new jobs by 2020, so it's a complicated relationship. But this leads to a great policy question. Potentially, one of the great policy questions of the next 10 years, why hasn't technology transformed labor productivity in healthcare when it has done so in virtually every other industry? Okay, so think about the last time you called a travel agent to book a flight. When was the last time you drove to the bank to talk to a bank teller about withdrawing money, right? Now, granted, healthcare is more complex than other service industries. The offerings are more diverse, but surely there are tasks and tests that could be automated or offered remotely. Okay, so next slide, please. So that leads to these two forces that are squeezing hospital margins, right? You heard from Chris the change on the horizon about the way healthcare is paid for. Bundled, at-risk, complete continuum of care, right? Population health. It's changing, and in addition, the fee-for-service model, which is still half of hospital revenue, the fee-for-service model is being trimmed, right? Reimbursement rates are being cut across the board. Labor costs are very difficult to take cost out. So we think there's going to be a need for disruption and a need for new models. So last slide, please. Part of the solution, we think, will be in the realm of digital health. So healthcare IT, connected workflows, mobile health, remote patient monitoring, smart sensors, remote care management, really the broad rubric of digital health. We think this is going to be a key role in resolving the new paradox for two reasons. When you are tasked with keeping patients out of the hospital, namely keeping people healthy, you need to, number one, closely monitor the costs that are happening in that bundle, and number two, report quality measures. So we think there's going to be a large need to underpin this with digital health and healthcare IT. The healthcare IT of today is more of a digitization of paper records. The IT and digital health of tomorrow will need to be something different, right, that will enable these new trends that we're talking about today. So that's my last slide, and back to the moderator.
Thanks so much. Laurie, you're up.
Well, just to tell you a bit about myself, my name is Laurie Orlov, and I founded Aging in Place Technology Watch and Boomer Health Tech Watch over the past 5 or 6 years. Prior to that, I was 9 years as an industry analyst at Forrester Research, and prior to that, I was 24 years in the IT industry, where I was a CIO in a couple of my last 2 jobs. If you could go to the next slide, I hope. There you go. Okay, so we're going to sit on this slide for a minute. The point of founding Aging in Place Technology Watch was really around the concept of successful aging, which, what is the definition of that? The ability to do things for myself, to feel safe, and to have good health. And therefore, aging in place is the ability to age successfully in your home of choice. So just to ground that, because we really are talking about an awful lot of the healthcare system being devoted to serving the 65-plus population, I thought I'd give you a few comments about that population. First of all, today there are 46.3 million people age 65-plus. There are 20 million people age 75-plus. 46% of the women age 75-plus live alone. There are 5 million people age 85-plus. Today, we have a new paradigm of life expectancy. That is, if you are a woman and you live to age 65, on average, your life expectancy is now 88.8. If you're a man, it's 86.6. So that is pretty important context in which to think about the use of technology for older adults. And I also want to point out that before 2010, there was no iPad. Today, even the mobile personal emergency response industry, which is the ability to wear a pendant around your neck outside of your house and actually press a button and get help, that is still only 10% of that industry. That industry is, in fact, going to intersect over time with the smartphone industry, but today it has not yet done so, and it's still a $1.5 billion industry. The other thing to understand about the population that we're talking about is 27% of the 65-plus today have smartphones. That's up about 10% from last year. And 59%, according to the latest Pew numbers, of the 65-plus have online access and go on the Internet. I think it's important to understand that when we look at this slide, which is about the categories of technologies that are appropriately serving the 65-plus population. So if you look at the upper left-hand category, those are all the communication technology categories, including email, chat, games, video, cell phones, smartphones, tablets, PCs, and Macs. And every year I seem to add another to that list. If you look at the bottom left-hand, because we know that 60% of workers who are age 65-plus actually are still working full-time, it's important for them to continue to hone their skills, to take courses online, to find work, and to volunteer. Not to mention, they want to use technologies to help them leave a legacy of information for their families, grandchildren, and so forth. If you look at the top right-hand of this puzzle, you'll see these are the safety and security technologies, which include personal emergency response, home security systems, fall detection, home monitoring, and inactivity monitoring, which unfortunately is still a very crude technology. We really, in every other type of fitness technology, for example, we know how much activity you've taken and whether you in fact should get up and go out for a walk. But inactivity monitoring of older adults has not yet really become common practice and a common technology. So if you look at the if you look at the bottom right, those are the health and wellness technologies, and it's important to think about that list of technologies there and understand the need to have the adoption boosted among the older population. Maybe mobile health applications as smartphone adoption grows, maybe as tablet adoption grows, but surely telehealth technologies for remote monitoring of chronic diseases, medication management to remind people to take their medications, and you know, all the kind of diagnostics that are possible for an older population. That is all really critical to helping people thrive in their own homes. And so that is the last of my comments on the categories of technology. The only other thing I would say about this is the reason you see caregiving in the middle is that it overlays the four categories in that caregivers, that would be family caregivers and professional caregivers, participate in all of the four categories of technology for older adults. They have a role to play, if you will, in helping people leverage all the other technologies. And the other thought would be that the reason this is shown as a puzzle is because without one of these segments, whether it's communication, safety and security, learning and contribution, or health and wellness, if you leave out one of these puzzle pieces, in fact, it is much harder to age successfully and thrive. And that's all I have to say about that. Back to the moderator.
Thank you. Well, I believe now we're going to turn over to Beckers to start fielding some of the questions that are coming in through the audience so our panelists can address them.
Absolutely. Thank you, presenters, for a very informative and enjoyable presentation, first of all. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for the Q&A, and we'll follow up on questions we do not have an opportunity to address. All right, so first things first, we have a question here from the audience. What disrupts labor today?
Yeah, so this really gets at a deeper question of technology and labor and how they work together in healthcare. Okay, so what disrupts labor today? What first gets disrupted by technology is routine tasks. Okay, that's really where practically labor gets disrupted. Anything that's a routine task that can be done automated, or what's called consumer added value, where you push over to the consumer, make the consumer do stuff on the web, right? Like book their own flights or make their own bank transfers, right? Those are the routine tasks that get disrupted first. The higher end cognitive stuff, and by the way, for everyone listening on the call, this is good advice for your kids, right? As you think about what are the jobs and skills required in the 21st century, right? Higher cognitive processes like diagnosis, or actually performing a surgery that requires tactile sensation and it requires pattern recognition, those are not going away anytime soon, right? There's promise of how technology will partner with us to get those higher cognitive tasks done, but anything that involves routine is ripe for automation or outsourcing.
Got it. Wonderful. Does anyone else want to weigh in on that question? No? All right. Moving along to the next question then. When do you expect there to be payment-specific resources available?
Sorry, can you repeat that question?
Yeah, absolutely. The question is, when do you expect there to be bundled payment-specific resources available?
And that one is for Chris, I believe. Yeah, I can kick us off on this one. So I'll answer this in a couple of perspectives from the Healthcare Transformation Task Force, because we have a specific focus on, one of our specific focuses on bundle payment, but also a note on where CMS is headed with bundle payment. So our work group, which is led by Steve Wiggins from Remedy Partners and Rich Roth from Dignity, and includes really a number of the leading lights in bundle payment work around the country, is in the middle of their first scope of work, which includes a really comprehensive environmental scan of all of the bundle payment work that's going on in both the public and commercial sectors. So that is in the field now, and the expectation is that this quarter that will come back, and that will inform the development of a tool that will be available in an open source format in the second half of this year. And so would encourage you to take a look and follow up. There's a sign up if you want to follow the work and be kept abreast of what's happening. But I would expect that, again, in the Q3, Q4 this year to have the development based on both the environmental scan and the intellectual property that folks are contributing to the work group to be available for the broader public. As far as CMS goes, as many folks probably know, bundle payment is a major focus of their work, alongside accountable care organizations, ACOs, as Mitch was talking about, and things like patient-centered medical homes. CMS is currently testing 48 different episodes of bundle payment. that span both the inpatient and post-acute settings. And my sense on this is that that will be, of all the models that CMS is currently testing, that one feels like it could be most ripe for an expansion nationally, including in a mandatory way in the next couple of years, using the full extent of the CMS Innovation Center's authority to take a concept that they've been proven in the demonstration phase and actually make it the permanent Medicare methodology without having to go back to Congress. So that one feels like it could be even in the next 18 months or so that you'd see CMS really doubling down on bundle payment for at least a portion of those 48 episodes.
Wonderful. The next question we have from the audience is, when will value-based purchasing initiatives include emergency services?
And again, I think that's for Chris, and he
Yeah.
has answered it broadly, I think, in his previous answer.
Yeah, I may not. Thanks, Mitch, and we'd encourage others to jump in here. But as I was trying to convey, I think the direction that public and private payers in particular are moving, with support from providers and consumers and other groups, is to move towards an orientation around total cost of care, whether that be, again, in a population-based approach like accountable care organizations or capitation, other forms of managed care that have been around for a long time, or increasingly in this bundle payment approach. The idea is that emergency services would be included because it's truly total cost and total quality of care and experience across the entire spectrum of care delivery. So you would expect, you will see emergency services be a part of those full bundles. I think there's seems to be less energy these days in creating specific site of care value-based purchasing programs. So I'm less, I think you're less likely to see that develop. It could happen on a payer-by-payer basis, but I think the broad movement is more towards bundles, whether population or episodic.
Got it. Would anyone else like to specify? Or no? All right, so the next question we have for the panel from the audience is, what is the probability that the U.S. will move to a single-payer system?
I mean, I can kick it off, and I think Chris is well positioned to follow up, which is we're already halfway there. If you look at the effect of CMS, so Medicare, Medicaid, and children's health insurance coverage and VA coverage, there's a large portion of the United States is under what you could call a single-payer system. Chris, over to you.
Yeah, certainly the Medicare program is federally financed and partly federally administered, though certainly a large and growing portion of that is a public-private partnership with health plans through Medicare Advantage. And increasingly, as you see things like the development of ACOs, is really looking for provider-led solutions. So yeah, I think, Mitch, I would agree that a greater proportion, and you look at the states that, again, have some mix of publicly administered, all publicly financed, some publicly administered, and some administered with private entities. Certainly the proportion of publicly financed healthcare is on the rise. I would say that I don't expect, quite frankly, to see much movement towards single payer for non-Medicare, non-Medicaid covered lives anytime soon. I think there's enough momentum in terms of implementing the changes that we have in front of us now, in terms of moving towards more regulated and appropriate insurance markets with things like exchanges and tax credits and the like to support the purchase of that private insurance. That doesn't feel like something we're headed towards very quickly, in my opinion.
Wonderful. The next question we have, Mitch, it's referring to a slide that you had that displayed a hospital surrounded by a health center and numerous other businesses. Does this suggest that hospitals need to venture into other business lines?
Yeah, you know, the slide was meant to convey how the landscape is changing. Certainly hospitals are very innovative in exploring new adjacent business models. You know, I think the first effect in the move to accountability is the merger and acquisition movement. So we've seen great activity with that over the last, let's say, 5 years. I think it's fair to say the activity of M&A and consolidation as providers try to ensure that they have a large enough population base. Why do they need that? Because it's a way to manage risk, right? When you are at risk for the payment and for the outcomes, you need to have a large enough population to manage that risk. And so I think that's triggered a lot of the M&A activity of the last 5 years, which has been more than the preceding 20 years. And I think that's the first, if you will, business move. In terms of innovation and how they get into health and wellness, there has been a lot of work previously in disease management. We'll see now that incentives become more and more aligned how that trend plays out, but I would call it adjacencies and experiments right now in innovation.
Great, thank you, Mitch. The next question we have from the audience is, along the lines of labor costs, do you predict that there will be an emphasis on patient care techs and lower cost nurses like LVNs and ADNs than BSN nurses?
Yeah, so there's, we call it the T's of labor. So you've got technology, you've got task shifting, and these are critical in enabling what is being described in this question. The third is the training, right? So the technology has to be easy enough for labor to use. Task shifting is a bigger, it involves the societies, right? Because what a certain healthcare provider can do is regulated and defined by their societies. And so there's going to be a lot of due process involved in task shifting. Some tasks will be more easy to transfer than others. And then the third is the training, right? So not only does the technology have to be easier to use in lower skill settings, but the training has to accompany that as well. And so we'll need to see more commitment to both the innovation side and also the training programs that will effectively allow the task shifting to take place. But those are the 3 T's that will have to happen together, we think.
Wonderful. The next question we have from the audience is, how will the industry and policy balance the financial and healthcare labor efficiency squeeze with the forecasted critical shortage of key clinical labor in this sector?
Yeah, I think, I'll kick this one off, but I think that gets back to the need for a new model, right? So what that question says is that these trends are not sustainable, right? So the reimbursement cuts in fee-for-service, the rising labor costs, the squeezed margins is not a sustainable model, right? So how do we ensure that our care providers, number one, that the supply is right, and number two, that they're adding the best value, and the solution that we're all heading towards, certainly on this call, and it seems to be where the United States is heading, is towards the accountable care model. And the whole purpose of that is to align incentives for all providers on the team to coordinate care, reduce redundant tests, improve outcomes, reduce errors, reduce cost. So that's the way it's going. How it will play out and how it will manifest in different moves and innovation remains to be seen. And others, please contribute.
Yeah, I'll just jump in here really quickly. I mean, I think implicit, Mitch, in what you're saying is that what this trend suggests is that hospitals, to survive and thrive, and other health systems are going to need to get closer to the healthcare premium dollar, if you will, whether that be through owning that premium directly in the form of a health plan or in the way in which they are contracting with their payers. But the closer that the provider is to the healthcare premium dollar, the more opportunity and there is to direct investments, including in labor, needed to achieve the triple aim outcomes, which I think in turn creates a more efficient use of and deployment of labor towards goals that serve the health system and the healthcare organization that's holding that risk in the best possible way. So in some ways, I think that to the extent this movement continues to accelerate, I think we're obviously seeing several trends converge here into a bit of a tipping point, that's going to require those on the delivery side to be closer to that premium dollar, which will push them to make resource, including allocation decisions, including labor, towards the best possible outcomes.
You know, the one thing I would add to this question about the how is this is a case where we should look to Europe to see what they do to solve this as well. So the entire European Union, under obvious fiscal constraints, right, have effectively capped their budgets for adding healthcare labor, right? And those economies, those countries being more oriented towards single-payer systems are able to do that. What that has created is a forecast gap. If you project out to 2020, so the increasing demand for healthcare driven by the demographics and a flat labor supply creates what we're calling a productivity gap of about 15%. Okay, so to address that by 2020, that's the equivalent of every healthcare worker across the European Union working an extra half day every week for free. Okay, now, do they solve it like that, or do they solve it some other way? It's going to be very pronounced there. What this question is asking is going to become very pronounced across the European Union, and we should probably keep one eye on how they solve this problem of labor productivity as well.
This is Laurie. I'd just like to jump in at this point and point out that to the degree that patients themselves can be more involved in keeping themselves well and out of the healthcare system, you would obviously see a reduction in demand on labor. However, I don't see patient portals as necessarily the way to make that happen, although maybe they have some potential over time. But how to keep people from having to go into institutions, which essentially puts that pressure on labor, I think that would require some level of thought and investment.
Well, thank you, guys. The next question we have is, the more complex information technology gets, the more difficult it is for older and ill patients to access and adopt and participate in new technology and programs. How are these issues being addressed as we push towards the adoption of healthcare information technology?
Well, I think I just answered that before it was asked.
Does anyone want to expand on it?
Yeah, this is Sean. Let me poke at that from a little bit different direction just to add to it. One of the things that I've seen coming out of the wellness and behavior change space predominantly, and then moving into the technology world, is that most technologies, whether they're web-based, in your hand, something you wear on your wrist, what have you, they're typically designed from a function and technology builder's perspective with a little bit of human being psychology sprinkled in. What we've noticed over the last 4 or 5 years as these technologies mature and engagement with these technologies tend to peak at certain age groups, companies are starting to understand that they need to understand human beings more and what motivates them. And the reality is you can get a lot of information from a person if they understand why it benefits them to give it to you, and that in some cases the actual use of technology isn't the answer. It may just simply be somebody answering a question on a survey, maybe on a tablet or through a phone call, and you can have as much information as you need as a care provider to take the actions that you need to take. And so one of the first things that we really focus on is, do you really need technology to solve the problem and get the information you need to get from the person? Is there a way they're already used to that can get that for you in a cost-effective manner? And if not, then you move on to new technologies.
Wonderful, thank you. So you guys have all discussed some numerous changes going on in the industry right now. One of the questions from the audience is, how are doctors reacting to these forces of change?
I'm sorry, how are they what?
How are doctors reacting to these forces of change?
I can kick this one off with how the doctor societies are reacting. So this is all published information now from ASCO, so the Society of Oncologists, from the ACC and the AHA, which captures cardiologists. And they are getting more actively involved in two things. Number one, task forces to understand what is the true cost of providing our services in the context of a full bundle, right? Number two, task forces around what constitutes a bundle. These are very interesting guidance documents and thought pieces that these three societies have put out in the last year, because what it suggests is they are going to become more proactive in helping to define what constitutes a bundle and what constitutes a reasonable payment for a bundle. I think that's a very, very interesting move on the landscape of how accountable care payments come together, is the move of these clinical societies into the game. And also, all of these documents that I'm referring to, they mention cost effectiveness. Okay, so they say potentially what this could mean is that they will not only evaluate clinical outcomes when making guidelines, recommendations, but potentially at some point in the future, and this will take a lot of due diligence and a lot of task force work, but they could be moving towards having opinions and having recommendations on cost effectiveness as well.
Yeah, this is Chris. I'll jump in here, and one thing that we didn't get a chance to talk about today, which is also an important new data point in this sense of growing momentum towards value-based care, is the seeming strong likelihood that the House and Senate will pass and the President will sign a pretty meaningful reform to the way that physicians are reimbursed and paid through Medicare, which has the full-throated support of just about every physician society, and that policy requires physicians to migrate into not just alternative payment models, but risk-bearing alternative payment models by 2019 in order to receive any kind of an update on their underlying fee-for-service payment from Medicare. So at a high level, at a policy level, that's something that is broadly supported in the physician community. And I think that speaks to the notion that a payment model that rewards the type of time and energy that you can spend in actually keeping people healthy and keeping them well and out of the hospital is the reason that many physicians went into their noble field in the first place, and that it's a way of practicing that's not necessarily been supported by the economics of fee-for-service. And I think there's also a lot of interest in moving to more comprehensive approaches as opposed to 5, 6, or 7 different types of value-based purchasing at a kind of an incremental level. So at a high policy level, it seems pretty clear that the physician community sees a lot of upside in this movement. Now, in terms of how it's felt on the ground, I mean, in our experience, there are a couple things. First is that for a health system, we find you actually need to have a so-called thing as a value-based business, something that you can actually invest in, something you can put physicians in leadership roles where they can actually help design and implement changes in the approach to care delivery consistent with these new accountable payment models. And to the extent that physicians are able to lead it and put their own stamp on it, and to the extent that it actually improves their life on a day-to-day basis, I think there's a lot of emphasis on physician compensation, and that certainly is a huge factor. But I think for a lot of doctors and other clinicians, they want the system to work better. They want things that can help them in their everyday workflow to do more and do better for their patients. And so I think that to the extent that a health system actually invests in a comprehensive approach in a business within a business focused on value-based care, there's an opportunity to deliver that, and the physicians will. There's the folks at Geisinger coined the triple aim +1, so not just better care, healthier populations and lower costs, but also improved clinician satisfaction.
Great, thanks guys. Another question we have from the audience here. Under the current reimbursement system, the cost savings does not seem to offset additional costs of an ACO plus the revenue loss from lower utilization. The question is, how do systems manage until the reimbursement method transitions period?
Well, it's a good point.
Yeah,
I mean, if you look at the ACA. Yeah, go ahead.
Go ahead. Well, I think this is it's a great example of a place where the kind of talk and signal setting, particularly from CMS, is starting to translate down into actual policy change. So in something like the accountable care or the ACO model, I think the feedback from the field has been consistent across not just providers, but other stakeholders, including consumer groups and payers and others, which is that the current approach to the ACO, particularly in Medicare, is one that doesn't have enough financial upside, quite frankly, to justify real investments in care management, particularly at a health system level where your population health business is going to cannibalize to some extent your hospital volume, and what you need to do is replace that with growing market share of truly necessary services. But to make those economics work, there needs to be a sufficient level of return. That hasn't existed in Medicare ACO up until now, in our opinion, in the new Track 3 in the Medicare Shared Savings Program, and particularly this new next generation ACO model that really replicates Medicare Advantage in its opportunity for full risk and reward, is one that I think solves that problem. The other issues have been around understanding and knowing your population ahead of time and what your benchmark is, and having some ability to create tools and incentives for consumers to seek care from high-performing providers. So CMS is starting to recognize that, starting in particular with the idea of there has to be a business case here, and until you start getting up into the types of returns that they're offering now in their newer models, Track 3 and Next Generation, the financing really hasn't worked out.
The one thing I'd add to Chris's point about the business model that we haven't talked about yet is large employers, and how large employers are negotiating to set up or agree on centers of excellence with key providers across the country, right? So you hear about these details in the press more commonly now, and it's the idea that a large employer will contract with a provider to provide, let's say, hip and knee replacements or perhaps cardiac procedures, but it is a form of bundling, right? It is a contracting to guarantee that we're going to fix the patient or the employee's problem within a set amount, right? And so negotiating with these kinds of contracting models to essentially ensure that they have a supply of patients that are well matched against their capabilities is what I would call an intermediate step away from fee-for-service towards the bundling and full ACO model that we expect to see with Medicare.
Fantastic. We have time for one more question. The question we have from the audience is directed towards Laurie. The question is, in light of the higher incidence of hearing and vision impairment in the population over 75 years of age, are there innovations currently being developed in senior home design and architecture to help those individuals age in place in their home other than assistive devices like hearing aids and eyeglasses?
You mean specific innovations in the home itself? There's not a nationwide building code that would comply with accessibility in the home. So at the moment, it's incumbent upon the homeowner to modify their home in advance of needing capabilities that a home could offer, including wider doorways, smaller thresholds, accessible showers, and so forth. So unfortunately, all of those kinds of things are still incumbent upon the homeowner. However, there have been some innovations, particularly in hearing, that provide alternatives for amplification that don't require the $4,000 or $5,000 hearing aid. That would include the personal sound amplification product, which can be bought at retail for $300 or $400, and provide really all of the amplification that a hearing aid does. It simply doesn't require an audiologist to tune it. As for magnification and vision technologies, other than the fact that any device you interact with, in fact, can be support magnification and zooming, I haven't seen anything beyond that.
Wonderful. Presenters, thank you again for your excellent presentation and for participating today. We look forward to having you join us for future webinars. This concludes today's program, and have a wonderful afternoon.